Hello, I'm Dr. David Hornbrook, the Clinical Director of Education Technology here at Keating Dental Arts in Irvine, California. This is our weekly podcast on Dental Up. We're very excited to have a repeat guest in Dr. Mark Montgomery. We spent some time together, Mark, for the last 20 years we've been great friends. We spent lots of time together, but we spent some time together talking about dentistry for our podcast back in May.
Yeah.
And we talked about sleep apnea and some of the stuff you're doing with pain control. But we're going to change topics here because, this is something that, working with these dentists at the dental lab as well as an educator and things you encounter as well, is this whole issue of dysfunctional forces and destruction in the mouth and how we deal with it, whether it be natural dentition, our patient comes in with some broken teeth and wondering why their teeth are breaking, or we decide we're going to restore, and we're not sure whether we can with long-term success.
Right.
Or we do restore and we don't have long-term success. So
Right.
Let's start by just looking at the evidence. A patient comes in, opens their mouth, and what are the things, there's some obvious and there's some things that aren't so obvious. What are the things that we see that's evidence of dysfunctional forces or dysfunction?
Yeah, I think the way that I look at things now is a little bit different than the way I did, 15 or 20 years ago. And the way I think about it now is when I see evidence of destruction or pathology on the teeth, I immediately ask myself, is this pathology related to acid, infection, or force? And it's real easy for me to look at several teeth and see what's going on and realize, okay, this is a force-related issue.
Right.
And if it's a force-related issue, then it's some sort of a dysfunctional or parafunctional problem that's creating abnormal forces on those teeth. So the evidence for that, we see that all the time, right?
Right.
It could be vertical fracture lines. It could be a cusp that comes off a tooth. It could be wear on the front teeth. It could be collapsing of the lower anteriors.
Endodontic treatment.
Endodontically treated teeth.
Tooth.
Yep. And we've seen a lot of cases where it's like a root canal after root canal after root canal, kind of hunting for where the pain
Right.
problem is, and never really evaluating the forces that are contributing to that to that dysfunction or that overload of forces. So I think about it like when I see single tooth problems, I realize that it's probably not a single tooth issue. It's a single tooth symptom of a larger force-related issue. And so I look at it like, what do I need to do with the chewing system in order to get control of forces?
Okay.
And my patients have gotten much more comfortable hearing me talk about these problems, not like, oh, you have a broken tooth that needs a crown, but like, oh, you have a broken tooth and you have a crack over here and you have receding gums over here and these front teeth are collapsing. I wonder where the abnormal forces are that are creating an imbalance in your chewing system.
Right.
And patients like the chewing system term. I don't know if our audience will appreciate that, but
Yeah, you've been using that for years, and I do like it. I do like it.
so I look at it like, here's some evidence that we have a chewing system problem, and let's find out what the issues are here that we need to control so that we can design the best result.
And I think it's gotten even more important now for two primary reasons. One is our patients are living longer, and so, and then we're not going to dentures, like we used to. So as they start to live longer and what we used to say the age-related problems and this dysfunction, we're seeing broken down dentition in their later years, which would be a huge problem.
Right.
And we tend to do more aesthetic dentistry on older patients.
Right.
So if we don't address the dysfunction and the causative factors, why their teeth are short and broken and chipped and ugly, and now all of a sudden a 65-year-old would decide, oh, let's give them a beautiful new smile because they have the money and they have the health and they could live for another 20 years. If we don't address those dysfunctional issues, we're going to see failure of this beautiful dentistry. And I've seen that in my own practice. So, let's talk about if you had to narrow the dysfunction. You categorize the breakdown being acid, erosion, or forces. Let's talk about the force-related dysfunction.
Okay. So when I see evidence of force-related problems, then I need to do a force evaluation. And that force evaluation is going to lead me into figuring out what are the issues I need to control. And almost always, those issues fall into a very narrow range of problems. And, 5 of them I would consider to be what I would call the setup or the foundational issues. They're almost like the issues you would think about when you're doing a reconstruction or an orthodontic case or a growth and development case, where we need to look at the aesthetics and the vertical dimension, the arch form of the patient, whether or not we have a good occlusal plane, and whether or not we have class 1 canines.
Right.
Those are what I would consider to be foundational issues. And those 5 things are pretty simple for us to take a look at and say, are those foundational issues in place? Mm-hmm. And even if we're going to optimize the smile with a small change, if those other things are still in line, then we can just go directly to looking at what the functional occlusal issues are. And I have 5 main things I look at there. Right.
So let's, because you said it very quickly, and just for our listeners' benefit. So as we look, patient comes in, and again, we tend to, as dentists, is fix the problem associated with. We're kind of like physicians.
Right.
Oh, you have an itch. Here's some hydrocortisone, and when the itch goes away, you're fine now, right? And so we see a sore tooth, and we either crown it because we think there's a crack somewhere, or we have a root canal done, and then we crown it and hope the patient has no more pain, and we move on.
But we don't look at what's the overall foundational issue underneath that. So here's my example of that. If you had a patient who came in and they had a broken front tooth, and you wanted to repair that one broken front tooth, when you do that, what are you going to match that front tooth to? Are you going to match that to a gorgeous smile that they already have? More than likely, that gorgeous smile is not there.
Right.
So if you choose to do one tooth in the middle of an ugly smile, you're going to be making an ugly crown to match an ugly smile.
Right.
So in other words, you're just fixing the symptom of the problem, and the patient doesn't necessarily get the benefit of our comprehensive experience or the everything that's available to them. They're not going to get the smile of their dreams.
Right.
If you have to match a single crown into
where there's wear and a bunch of stuff going on, right?
Right. Or just color issues. Yeah. So just like we would look at a broken front tooth and say, are we going to match this in, and is that going to be ideal for this patient's smile? Is this going to match their values and their desires and their dreams?
Right.
If their answer is yes, then you go ahead and do a single or 2 units and you make it gorgeous and you make it match. But many times, the reason that one tooth is broken or that one tooth is ugly is because of the whole smile is not that great. So you give them an opportunity to treat the foundational issue. It's the same with function, that if there's a single tooth that's fractured or broken, sometimes I just ask my patient, why do you think that tooth broke?
Right.
And there's only 2 reasons. Either that tooth really was too weak, or there's too much force.
Right.
If there's too much force, that's a whole arch problem. It's not a one tooth problem.
Oh, yeah. Yeah, but we go in and we take it out of occlusion.
Right.
Or the patient takes that out of occlusion by breaking the porcelain off of
and when you take the forces off of that, those forces go somewhere else. Mm-hmm. So as soon as you take that one tooth out of occlusion, then those forces go somewhere else, and then they break another tooth.
We see that clinically, where a patient has an MOD amalgam on tooth number 30. They break it, then they have a root canal and a crown, which probably was sensitive, so they took it slightly out of occlusion. And 3 or 4 months later, all of a sudden, the opposite first molar needs a root canal too, as well.
Right.
And it has a kind of a shallow amalgam. And you think, why did that go to a root canal when it's not infection related?
Nope.
It's force and trauma related. And you're right, we chase teeth until everyone has a root canal, I guess.
Well,
bottom line, hopefully not. But.
We chase the forces around the mouth instead of looking at balancing the system. And if we could, like we talked about the chewing system, if we can bring the chewing system into balance, that's like giving them a brand new smile.
Yep.
It gives them a brand new future of stability and confidence that their teeth are not going to come apart.
Yeah, and if they're young and they can't afford a bunch of restorative, you can slow down or maybe even stop a lot of those destructive forces. So they're not in the same boat that they would have been 40 years from now or 30 years from now.
You mean that we could actually be preventive?
Yeah, that's right.
And,
yeah.
Dentistry has led the prevention movement, but
Right.
really, sometimes I think we want to put ourselves out of business. No, I'm just
Yeah.
kidding. But prevention really is optimum for patients who don't want to get in the situation where they have to rebuild everything. And if we can keep that in mind, I think that we can do our patients a huge favor by taking care of these foundational issues as a foundational issue and not what I call pushing the easy button.
Right.
Say, oh, you broke a tooth, easy button, put one crown on.
Right.
The real thing is to say, what's the underlying force problem? And if we deal with that and put that crown on, now that patient's set up for a lifetime of success.
Yeah, and people say, oh, we're artists, we're little mini engineers, and we take pride in that. Yet if a strut on a bridge broke, the engineer wouldn't just fix that strut. They would say, you know what caused that? And the fact that it broke, and even that short little time that it was fatigued, how did it affect those other struts and how those supporting rods, where we just go and replace it and say, oh, everything's good, we'll just wait for another one to break.
Right.
And that could be catastrophic, in a bridge scenario or in the mouth where they could lose a tooth or could go to endodontics.
And not only that, it doesn't help our relationship with the patient when they have problem after problem after problem after problem. Pretty soon they think, do we really know what's going on here?
Right.
And so it's really beneficial to our relationship with the patient to, take a step back and say, I think this might be a chewing system imbalance. Let's do a diagnosis on that. Let's see if that's what's going on. And if there is, let's balance the foundation and crown that tooth. Now the patient's set up for success.
Right. So let's talk. You said them before, but again, I want to summarize them again as we look at the initial foundation, beginning with the smile design. I mean,
Sure.
Is a smile nice? And this could be a patient that, okay, so you come in and you have worn dentition, or you want a nicer smile, your teeth are yellow, or you've had some porcelain fused metal crowns in the past and you think they're ugly and I'm going to do that. Or it could be someone that has their natural dentition that you decide, this might be better treated orthodontically to get us in a position. Maybe we want to restore after orthodontics,
Right.
but to get them in a position. So, what is that checkoff sheet again? Why don't you go over it a little slower again? We'll talk about why those are important.
So the thing we're going to look at first is we're going to look at optimizing their smile. Because just like with dentures, everything starts with the two central incisors, and we've done that for years. And
Right.
and it's a way of taking a look at the patient and saying, if the smile is in great shape, if it looks right, it might be pretty close.
Right. Yeah.
Right. So we want to say, is the smile in pretty good shape? And we see a lot of patients these days who maybe they had orthodontics and their front teeth look pretty good and they need some whitening, but they have a bunch of posterior restorations that need to be done.
Right.
So if the smile is close, that's our first foundational issue. The second issue is, what's our vertical dimension? Is this patient's lower face height collapsing? Is it compromising their chewing ability? Is it creating pain or a lack of space for their tongue or their airway? So we need to take a look at the vertical dimension. In the scenario I said, where a patient maybe had orthodontics previously and they just have some posterior restorative that needs to be done, maybe the vertical dimension's pretty close.
Right.
So
And in the vertical dimension, we actually have a bonus as part of this, because Mark and I spent about 45 minutes talking ahead of time. If you go to dentalup.xyz, we have actually what we call our video whiteboard, where Mark and I are just talking about these things. It goes much deeper than we're going now in things like envelope of function.
Sure.
Anteriorly. So, we see all the time lack of vertical. Now we have a deep overbite, which now we trap the mandible in, which
Right.
is going to cause destruction as well.
Right. So we want to make sure we have our smile optimized and our vertical dimensions is close. And those are our first two things. And then our arch form. Do we have narrow arches or normal arch form? Some people say, well, how do we know if we have a normal arch form? Well, borrow an arch wire from your orthodontist and see if it lays right around your model. If the teeth fit on the arch wire, then you're probably pretty close. If they're inside of that arch wire, then it's probably a narrow arch.
Yeah.
So I would just take a look at their arch form, make sure it's not too narrow.
And some of the evidence is that too is, we see it post-ortho on adults now that had ortho when they were teenagers 20, 30 years ago, where everything is brought back to close those spaces after the extractions were done. But also, and this is, you talk about this a lot, is lingualized dentition, where especially mandibular molars, where they're angled in like this,
Yeah.
which means we can never really have cusp-fossa relationships.
Well, if you're not
And the
chewing
posterior.
on the cusp tips on those posterior teeth, if you're chewing on the facial surface of those molars, it's almost a 98% certainty that patient's going to be a clincher. So we need to get the contacts axially on that, and if you have a narrow arch, it's very difficult to do. So arch form is the next thing I look at. So that's smile, vertical dimension, arch form, and then the next thing I look at is, do we have a level occlusal plane, both aesthetically and functionally? Is it level? The more level the occlusal plane, the better cusp-fossa relationships we can have, the better tooth anatomy we can have. So we'd like that to be level if we can.
Now, as you're going through this mental list, obviously, you're thinking, okay, is this something that I've got to call my buddy the orthodontist, or is this something I can do restoratively? I did a case a couple weeks ago where it wasn't a level occlusal plane. Patient, a successful stockbroker, didn't want to go through. Ortho was not an option for him.
Right.
That we actually did these little overlays on a couple teeth just to level the plane. Did some enamelplasty up top. We can do it restoratively.
Right.
Or sometimes it's like, unless we do 28 teeth,
Yeah.
then no, this is not a restorative concern. So these are kind of mental lists that, or as you look at it, you think, is this something that I should have a conversation with my patient? We could fix this with glass or restorative, or we need to have a consult with an orthodontist.
And we have so many great options available to us. Let's take like that two-step occlusion that you were talking about just now, where the lower anteriors are a little too tall and the lower posteriors are a little too short. And you can come in and put some overlays in, and that will slightly open the vertical dimension, which gives you a better envelope of function, a better vertical, and you have total control of your case. So that's a great option. Could you also shorten the lower anteriors? If you're close, maybe, but I don't like to lose enamel.
Right.
Or could you do Invisalign and intrude the lower anteriors 1 or 2 millimeters, and then reestablish your upper smile design? So there are a lot of combination possibilities.
Right.
But the key is, are we thinking in terms of the arch and the foundation?
Right.
And that's why these things are foundational. Smile, vertical dimension, arch form, and then a lower or the level occlusal plane. And then the last thing that I consider foundational in my cases is a good class 1 canine to help support normal condylar chewing.
Yeah, talk a little bit about that, because you've been talking about it for years, and again, a lot of, especially restorative dentists, they just look and say, can I lengthen and give them a nice smile? So talk about this whole class 1 canine and the importance of that.
Well, if you think about it, when a patient's chewing, let's say this is the left side of the patient, so this is the front tooth, or this is the canine on the left, and it's a class 2 canine. And you can have them slide off to the side, and they kind of slide up that canine, or maybe they slip back in into the premolar space. But that's not really, the guidance of that is not what I'm looking at. What I'm looking at is when they're chewing a bolus of food, does this lower canine function off of the distal of that upper canine? And if it's a class 2, it does. And when it functions off the distal of that canine, maybe you're chewing something hard or tough, and or skinny like salad, as you're chewing that has a tendency to distalize that condyle on that left side.
Okay.
And so it's the class 2 canine it's not just a matter of guidance. It's a matter of
Chewing.
Is it stabilizing the condyle when you're chewing? Okay. And a class 1 canine, as you're chewing under that, has a tendency to support that mandible in that final crushing closure position, so that the condyles don't go distally. They don't push up against the retrodiscal tissue and create inflammation. The discs don't pop out as easily. It supports the canine more normally, or the condyle more normally, when you have a class 1 canine.
So do you see patients that do have class 2 canines or not ideal class 1, because the brain does not like pain in our joint, are they posturing forward and doing more anterior chewing then?
Sometimes they do, or sometimes they just have a lot of extra muscle activity trying to do their very best to stabilize that condyle during chewing, and then sometimes you get hyperactive muscles and you get some tenderness or some pain or soreness and things like that. And it's not, well, you've probably talked to a lot of people who say, oh, I chew gum, but my muscles really hurt when I chew gum. Well, that's an example of when that condyle is not being well supported, then the muscles have to compensate for that. So it's not I wouldn't say it's a have to on every patient, but from a physiological functional standpoint, it's better to have a class 1 canine than a class 2 canine, just during chewing.
Okay. So as you tell your orthodontist, so those are things you're going to tell your orthodontist. Instead of straighten Billy's teeth, these are the things I want. Level occlusal plane, class 1 canines. And then the orthodontist, which is adult ortho, where there's already destruction of maybe some anterior teeth or mandibular canines, no points, they'll come back and say, listen, I can't do it because of this reason. I need you to help me restoratively.
Right.
Yeah, which is a conversation that doesn't happen very often. Usually it's, we call the orthodontist, can you help me get things more ideal? It's not the orthodontist that says, I can get close, but I need your help with a point on a lower canine or enamelplasty or...
Right, or maybe the orthodontist says, I can't get you a full class 1 canine, but I can get it close if we do some interproximal reduction on the premolars or whatever that might be. Or they might say, well, if I move that canine back, I'm going to end up with spaces around my anteriors. Those kind of conversations need to happen because maybe we want that space around the anteriors to create a larger lateral incisor with some ceramic or some bonding.
Or maybe we are going to do restorative, and so we'd rather have your canines ideal, and you'll just close those spaces with your restorative.
Perfect.
Whether it be direct bonding or restorative.
Exactly. So those are my 5 foundational issues. Smile, vertical dimension, arch form, occlusal plane, and then class 1 canine. Those are my foundational issues.
Okay.
And if those are pretty close, then I can get into, okay, what are the occlusion related or the functional forces that I need to control.
Okay, and again, we've had this conversation a bunch. I always learn something from you, and I appreciate it. What are some of those things? I know that overjet, overbite, and that's
my first thing. So when it comes to controlling the actual chewing function with the teeth, my number one thing is overjet, overbite ratio, or what some people would call anterior envelope of function. That I need room underneath these front teeth for my mandible to come in normally. Some people talk about the lower incisor trajectory. Some people talk about whether or not you have a deep overbite. If it's deep and tight, then you can't have a normal trajectory. So we want to create a normal trajectory with normal looking teeth and a normal vertical, and that means that we need a good overbite overjet ratio with the anteriors coupled. So for me, that ratio is overjet to overbite of approximately 50 to 70%. If it's less than 50%, it's too tight.
So what would the evidence of that be? So, someone comes in, they've got 100% overbite. What would I expect to see in the world of their destruction?
Well, it could be many, many things. It could be ongoing collapsing of the lower anteriors. It could be ongoing retroclining of the entire anterior.
And we hear that all the
segment.
time. Patient says, it seems like my teeth are getting more crooked.
Right. Exactly. Yeah. And we don't have any room to straighten them because the upper front teeth are in the way.
Right.
So this is a problem restoratively, but it's also, that's evidence that this is ongoing. Sometimes we see that as wear on the lingual of the upper. incisors, or we'll see a flattening of the facial surface of the lower incisors. So whether it's wear or wear patterns, that's one evidence. The other evidence of that is that a lot of cases, like let's take a severe case where you have a class 2 div 2 anterior, where that upper anterior is tucked back and a deep overbite. Not only do you have a tight envelope of function in the front, but that's every time that patient chews, they have to bring their mandible underneath that, and that distalizes the condyle as well. It's almost like a class 2 canine from a functional standpoint. So it destabilizes your disc condyle apparatus. I want to support that better. So if I can get this into a more normal overbite overjet ratio, then I don't have as much inflammation in my joints, chance of popping and clicking and TMJ problems and things like that. So this envelope of function in the front is very important for controlling posterior forces, for controlling condylar position, and for controlling incisor trajectory, and allowing us to have the right functional apparatus for a beautiful smile.
And a good way to check that is like even when I do my restorative in the anterior, I'm changing length and I don't want to trap this patient in. Just take articulating paper and have them chew around a little bit, and you'll see instead of that point contact, you'll see huge blue or red marks on that whole lingual from the incisal edge all the way down to where that centric or that ICP is.
And once again, just like in the posterior, if you have contact on that facial of those lower incisors instead of on the incisal edge, when you have contact on the facial surface there, tendency is more force. So it's going to increase the forces on those teeth.
And we see more clenching.
More clenching.
Typically more
Absolutely.
Clenching.
So then my second thing is to create normal tooth anatomy. Great cusp groove anatomy with axial loading. I think that it's something that's a hallmark of the dentistry that we've done, is to create beautiful teeth.
I call them teeth at work.
Teeth at work. Back teeth that match the front teeth when we do beautiful smile. That's important. And then my last three things all have to do with force control. So number one thing, overjet overbite ratio. Number two, beautiful.
And that's 50 to 70%.
Yep.
Whichever that you like. Okay.
Overjet to overbite ratio, more than 50%, 50 to 70%. Second thing is normal tooth anatomy. And then my third thing is balanced forces, left, right. So the patient's got forces that are balanced in symmetry. The next thing is the force distribution good around all the teeth? And then the last thing is, do I have immediate anterior canine guidance to control forces that would trigger avoidance patterns during chewing? So overjet, overbite, cusp groove anatomy, balancing the forces left, right, balancing the forces around the arch, and making sure that the forces are under control during chewing with no working or balancing interferences. If we can do that, then we're going to have total control of these issues that patients bump up against.
Right. And like we've kind of reiterated through this conversation is post-ortho, because a lot of orthodontists do not finish the cases there should be. So maybe we have to go in and we have to remove some of those interferences. Our diagnostic wax-ups or our restorative cases, those are things that every single one of my diagnostic wax-ups, ideal tooth anatomy,
Overjet, overbite ratio.
Immediate canine guidance, pure axial force on posteriors only.
Right.
Anatomy that they look like teeth,
Right.
basically.
And do I have contact on all the teeth?
Absolutely.
I mean, you want to get a situation where the forces are well distributed, and we can determine all of that now. This is a slam dunk because we have that mindset. It allows us to think in terms of the overall force system, the overall chewing system. Can we bring this back into balance for our patients? And when we do, then we have better control over these destructive pathologies that we have. So whether we do it in order to design a beautiful restorative case, or we do it as a preventive concern, or we do it for pain management, this type of approach, aesthetics and function at the same time, gives us the ability to treatment plan and design a case that the patient can be confident in.
Yeah, awesome. Well, we're reaching our 30 minute mark, and we try to limit this to our 30 minutes. We can talk all day.
We
don't get
usually
to
do.
Yeah, I know. We don't get to spend end night. I hope you enjoyed this. Kind of opens up some ideas. You're thinking, oh, I didn't think of that, or I heard it one time and I forgot about it, or maybe that's why things are breaking, or our patients moving forward in a direction I don't want them to go. And so, as I mentioned, go to www.dentalup, all one word, .xyz for some of Mark's other videos, as well as a very cool thing we did earlier today where we just talked in more depth about some of the things we just talked about. And you can see that on a whiteboard so that instead of trying to keep up and take notes and put it on pause, you can actually see the writing on the board. And Mark, they can get a hold of you. Your email address is probably best.
Mark@montgomerymethod.com.
Okay, and if you could email him directly if you have any questions or concerns. He's great about getting back with you if you have a case that perplexes or confuses you. That's a great resource. In the meantime, I'm at Keating Dental Arts in Irvine, California. If you're ever in Laguna, Newport, Disneyland, Knott's Berry Farm area, be sure to come by and give us a call and come by and see our beautiful laboratory. Hope I see you again, and I hope you enjoyed this last half hour with us.